whenever you have a new drug for a disease state that has nothing, everyone and their mother thinks that it is for them. And we know alopecia span a very broad spectrum. So we'll go into the multitude of off-label offerings we have for these patients. Given this off-label, absolutely no disclosure to really provide. So I mentioned before, we are the off-label bandits. But what I did not mention is that major agencies are trying to stop us. They're trying to put us away, or rather take our toys away from us and limit our ability to really provide the plethora of drugs that do not have the indication, but we know will work for a wide array of diseases. So this is how I see us, right? We have to protect our off-label therapies. But in thinking about that protection, we also have to be purposeful. We can't be like this, giving out off-label therapies left and right. We need to be very targeted. We need to understand why we're using them and use them in an effective and safe manner. So we have so many wonderful toys, and I'm not even really going to get into biologics, though I will at the very end, just a smidge, just a tiny bit. But we have a lot of long-standing therapies, oral therapies, even topical therapies, been around for a very long time. So I'm going to dive into how we can utilize them in the world of alopecia. So first things first, when you're thinking about alopecias, you should have a bifurcation in the road. Scarring, non-scarring. That is the first thing you want to determine, and that will dictate what you do next. So you want to look for, is the scalp healthy? Is the follicular ostia intact? That will certainly push you in different directions. It also may make you more aggressive, because with scarring alopecia, time is hair. You want to get aggressive, you want to take that kitchen sink approach, whereas non-scarring alopecia, depending on the scenario, you may ease in and kind of take a more progressive approach. So let's start with non-scarring alopecias. Obviously, most notably, most common, AGA, androgenic alopecia. We do have two on-label therapies, topical minoxidil in several forms, as well as finasteride, whereas we still do other things that are off-label. Oral minoxidil has really come back into the fray, and I'm going to talk a little bit more about that. PRP, obviously, cosmesis, wigs, things like that. Yet women only have on-label. Actually, it was only until recently that 5% was made appropriate for women. They had the 2%, which really didn't do a whole lot. And for some reason, the 5% foam for women and men, same exact thing, it actually costs more, which is absurd. So I tell all patients, men or women, get the 5% foam for men, because you get in a tri-pack, multiple at once, so it lasts longer, and you get more bang for your buck. But the rest, minoxidil, finasteride, dutasteride, spironolactone, these are off-label. Now, I'm not going to talk a lot about spironolactone. However, I just want to make a plug for it. Very effective. There are some clinical studies looking at it. The doses tend to need to be a little higher, though there was one study showing that 50 milligrams twice a day is effective. I find I have to go a little bit higher. And this is going to be more for your childbearing population. Also of note, we showed at GW that spironolactone can be used in the setting of breast cancer survivorship. It does not increase the return or recurrence of breast cancer or hormonal-sensitive cancers. So that's certainly a big win for those patients. And then, of course, like men, there are other physical options as well. This was a great study published in JAMA Derm where they collected all of the trials, many of which were more just kind of like small studies, not FDA trials, to try to determine what was the best approach and kind of stagger them and kind of prioritize them. The most effective treatment was 0.5 milligrams per day of oral dutasteride. I will say, in my practice, I use a lot of 5 milligrams of finasteride for women. This study pushed me, and I have used dutasteride in the past, but definitely has pushed me to use more of that. Just under that 5 milligrams of finasteride, 5 milligrams a day of minoxidil, which I tend not to use that dose because of side effects, and then you can read the rest as you kind of go down. So oral minoxidil, the whole thing about topical came about because they were using this for blood pressure, and it turned people into werewolves, which didn't work out so well for those patients. So then it was like, well, let's make it topical to avoid those side effects. However, we find at subclinical dosing for hypertension, you still can have the pro-hair growth component or promotion of hair growth. And I usually will use maybe about 1.25 milligrams to start, half of the small size tab. Super cheap, super accessible. Yes, hypertrichosis can be seen, but I find not so frequently at that 1.25, and it will cause, just like the topical, an initial effluvium when you first start it. So I have to tell patients about that. Just a quick update on biotin. Lots of evidence showing it's not worth it, does not work, and it can interfere with certain blood tests that could be life-threatening. So I'm not going to belabor this, just say no. That was totally unnecessary, but I'll take it. All right, alopecia areata, Joe alluded to, we now have a systemic FDA-approved option, so I'm not going to talk about it. Just of note, I find often we kind of have a historical picture of who this affects, and actually there's some emerging evidence that we do see a good amount in specific demographics. So when you think of a patient who comes in, and don't be biased if you hear Black woman here with hair loss, assume that it's maybe historical hair losses and scarring hair losses we see in that population. Everybody gets alopecia areata, so I just wanted to make that point. What are our treatments? Topicals tend not to work so well. I think they're good to use at home as maintenance therapy, but intralesional, and there's a study showing there's no difference between 2.5 and 5 mg per cc, so I think go lower to avoid atrophy. I use a lot of intramuscular Kenalog, and there's a nice data, I'll talk about that in a moment. And then if someone is really bad, I'll bridge them with oral prednisone to get the other drug on board. I don't use a lot of oral or topical minoxidil, sometimes just to kind of get that hair back, especially if someone has a family history of AGA. There's some evidence for non-sedating antihistamines. I've tried it, doesn't really work. Also, I think getting them involved support groups like the National Alopecia Areata Foundation can be very helpful. So in terms of intramuscular Kenalog, we actually do have some good longitudinal data. It's almost like you get the effects of oral prednisone without the side effects like HbA acid suppression, like hyperglycemia, like increased blood pressure. So it is a good option. This is another paper kind of looking at that as well. I typically try to do it quarterly, so Q3 months. Alopecia areata, I find you have to do it monthly for a couple of months to really get the full effect. You always want to aim for the upper outer corner of the buttock to avoid any deeper nerves. You need at least a 1-inch needle, and you're probably going to go for a 25 or 27 gauge needle to get out that 40 mg of Kenalog. Oral minoxidil, it's out there. They used a much higher dose than I would actually consider using. It was okay. I really don't use it in this area. Cyclosporin, spelled incorrectly here, my apologies. That was one of my go-tos a long time ago. I was using a lot of off-label JAK inhibitors. I was getting them particularly from India, but it does work really well. And so I'm not going to read this, but it is in your handout. We published this step-by-step approach of how you combine a prolonged prednisone taper and cyclosporin to get this patient with alopecia universalis back to a full head of hair. So if you consider using it, certainly you can look at this algorithm. How to do it, there is some significant blood monitoring, so I do list it here. A lot of this is pulled from the JAD, which has really great guidance if you ever wonder how to use some of these drugs. What's also nice is because you can't keep them on it forever, that doesn't mean you can't do a modified dosing ongoing. In this study, they showed that if once you get clearance or once you get improvement, you go to weekend dosing only, you can maintain the effect without a lot of the side effects of long-term cyclosporin use. Okay, let's get into scarring alopecias. Lichen planopilaris, frontal fibrosing alopecia, a lot of discord. Are these two diseases in the same spectrum? Are they unique? TBD, they seem similar histologically, affects all demographics, so important to remember that. A lot of things you can do, but I think, once again, scarring alopecia, time is hair, hit them hard. Ultra-potent topical steroids, intralesional Kenalog. I often will start multiple therapies, maybe a combination of hydroxychloroquine and doxycycline at the same time, and kind of go up from there. But there's a lot of evidence out there, I say a lot, in the scheme of things, a lot of evidence for this rare disease, like PPAR gamma agonists, like pioglitazone. I do start these patients, when I think about anti-inflammatory, same time, I start them on anti-hormonal therapy as well, because I want to make sure if I'm trying to protect and save their damaged hair, I want the hair growing back the way it's meant to, undisturbed by androgen influence. So there's the anti-inflammatory part, but then I'm also throwing in the anti-hormonal part, especially in FFA. So antimalarials have been around for a really long time. I mentioned them yesterday with respect to some of the discussions with that collagen vascular disease case, that discoid lupus case. So it's kind of the poison we know the safety related to it. MOA, we're not 100% sure, but it seems to do a lot. And its different MOAs have different implications for certain diseases. I mentioned yesterday, it does have a photoprotective effect. There is data showing that it decreases one's sensitivity to UV radiation, but has a lot of anti-inflammatory properties. And therefore, it's been looked at in a whole host of different diseases, including lichen planopilaris and FFA. Reminder of dosing, less than or equal to at most 5 mg per kg of true, not ideal body weight, has a long half-life. So if you want to do the alternate day dosing because of GI upset, totally cool. Be my guest. Go for it. PK is absorbed by GI tract, renally excreted, but remember, it can concentrate in certain tissues. That's the whole eye issue. It can concentrate in melanin-containing cells like the retina. And this was just from yesterday. Just a reminder, don't do G6PD, not necessary. No smoking because it interferes with drug. Ocular toxicity is really going to be the big concern, but that's a long-term, down the road, years from now concern. Low-dose naltrexone is getting a lot of attention. This is off-label, but also unavailable commercially. You have to have it compounded. At lower concentrations, like 3 milligrams a day, it temporarily blocks the opioid receptor, and that causes a paradoxical increase in opioid growth factor and its receptor, which has a lot of cool properties. Promotes wound healing based on Rob Kirsner's work, inhibits cell growth, reduces inflammation. So a lot more to learn, but certainly it's a kind of no-brainer because it's very safe, well-tolerated, and maybe actually helps. And there's a lot in the literature, these kind of one-off case reports, here with dermatomyositis, Haley disease, which you wouldn't necessarily think, how would that work for acantholytic disease? Honestly, these patients are so miserable, who cares if it works? How it works? It does. And then, of course, Jerry Shapiro has done a yeoman's job proving that this is a nice add-on to your doxy and hydroxychloroquine or others for lichen planopilaris. Central centrifugal cicatricial alopecia, say that 5 times fast. It's a CCCA for short. Extraordinarily disabling disease. 2 key pointers to start. One of the classic signs, I think, of active disease is not erythema, but what I call the sponge sign. You press the scalp, it feels kind of spongy. Not boggy like dissecting cellulitis, but it feels very compressible and bounces back. Number 2, tell your patients it's not their fault. These patients are told, it's because of your hairstyle, it's because you did this. That is adding to the disability here. It is not their fault at all. And also, get ready for that dirty, disgusting kitchen sink that you're going to throw at these patients. So I think it's important to discuss the genetic predilection of this. There was a nice New England Journal of Medicine paper identifying a gene mutation and also identifying comorbidities like uterine fibroids. So patients are always like freaked out when I see this, and I'm like, do you happen to have fibroids? What? Yeah, how'd you know that? And they're looking down to make sure they're like fully clothed, even though not like I could see the fibroids if they weren't. You can biopsy, I got one laugh. You can biopsy, but I find it's not that helpful, and this is pretty much a clinical disease. Also, recommend the support groups. This is an extremely disabling condition, both from a symptomatic standpoint, it hurts, it itches, but also from a very personal, emotional one. Many people, I'd say everyone considers their hair, their crown. And I think it can be very disabling for this progressive scarring process, for which if we wait too long, we can't do a whole lot about. So here's my algorithm, kind of 3-step approach. 1, preventive. Yes, tight, pulling, traumatic hairstyles and injury to the scalp will make this work. It will Kebnerize in some respect. So you gotta talk about that. Anti-inflammatory, I throw a lot at them. High potency topical steroid. Now, for a lot of these patients, they actually would prefer an ointment. I know we always taught don't put an ointment on the scalp, can cause hair loss. A lot of these patients prefer an ointment because they use grease anyway to soften some of the kind of roughness of hair. So offer the vehicles available, let them choose. I go higher with interlesional catalog. So instead of like maybe 2.5 for AA, I'm going 10, maybe 20 mgs per cc. And we're doing this ongoing. They're coming back monthly. And then we use a whole host of similarly hydroxychloroquine, doxycycline. I've even used Clinda or rifampin together, and even some immunosuppressants. And as I said, at the same time, you're adding the anti-hormonal. Now I'm doing more dutasteride than finasteride, and in this case, I will use oral minoxidil. So there's a lot you can do, but you gotta don't stagger it. Throw it all at once. If you get them better and they'll love you for it, you can start to pull things away. Last considerations, lots of opportunities for biologics based on what they target and the disease you're going after, though sadly for a lot of these alopecias, we don't know why they happen. One example, this is a patient with Graham-Little-Picardi-Lesaux syndrome, which is extraordinarily resistant condition that's in the lichen planus family, where they get LPP, LP of the body, and non-scarring alopecia of the axilla. Put this patient on secukinumab. At 12 weeks, substantial improvement. She had these eroded areas that she'd been picking because they were so porotic. Substantial improvement just on an IL-17 antagonist. So with that, I encourage you to harness your Doc Brown, harness your Jedi Voodoo, whatever, but use what you got before you, get creative, and help these patients. Thank you so much.